Hello everyone and welcome back. In today's lecture, we are going to talk about insulin, the hormone. We are also going to discuss its biosynthesis, how it is regulated, how it acts at the molecular level, and finally the different insulin preparations that are used clinically. So let's start. So before we discuss about the diabetes, about the insulin, we need to understand the diabetes mellitus first. So, diabetes mellitus is a metabolic disorder which is characterized by hyperglycemia, glycosuria. Hyperglycemia means high blood sugar, glycosuria means presence of sugar in urine, hyperlipidemia, negative nitrogen balance, and ketonemia, that is, presence of ketone bodies in the bloodstream. We classify diabetes into two broad types, while there are many other types also which exist. The type 1 diabetes is also known as insulin dependent diabetes mellitus IDDM, or we also call it juvenile onset diabetes. In this case, the patients have an absolute deficiency of insulin, so they require insulin replacement therapy for survival. On the other hand, the type 2 diabetes is also known as non insulin dependent diabetes mellitus or maturity onset form. These patients are managed either with oral hypoglycemics alone or oral hypoglycemics in combination with insulin. In this lecture, we are more concerned about the type 2 diabetes and its pathogenesis, because type 1 diabetes we already know is only treated with insulin replacement therapy. So to understand the pathogenesis of insulin, we must of the diabetes, we need to understand that the type 2 diabetes is caused by a triangle of three abnormalities. And these three abnormalities are glucoreceptor defect, peripheral resistance, and hyperglycemic hormones, that means the excess release of these hormones into the bloodstream. So, if you talk about the glucoreceptor defect, this is a defect which happens on the beta cells which only respond to a higher glucose concentration than the normal glucose concentration that is present in the bloodstream. Or there can be a relative deficiency of the beta cells that leads to automatic downregulation of the total amount of absolute number of glucoreceptors that are present on the beta cells. The second cause is the peripheral resistance, where the tissue becomes less sensitive to insulin's actions, and this is primarily due to downregulation of the insulin receptors in the muscles and the adipose tissue. And the third cause is the presence of excess amount of glucagon in the bloodstream, which is primarily driven by obesity and other metabolic causes. Now let's talk about insulin. The structure on your screen is of an insulin molecule, which is a peptide molecule. This molecule was discovered in 1921 by the scientists Banting and Best. That was a landmark moment in the medicine. Structurally, this insulin is composed of two chains of polypeptides containing total of 51 amino acids and having a molecular weight of approximately 6,000. The two chains are held together by the disulfide bond. The A chain contains 21 amino acids, whereas the B chain contains 30 amino acids. It's worth noting that the human, porcine, and the bovine insulins have a similar peptide structures, barring the difference of a few amino acids. That is why the first insulin that was used in the humans for the treatment of diabetes was the animal derived insulins. They were used in humans, although because of presence of some other extracts like C peptides and proinsulins and other some proteins, the use of these insulins were associated with a significant amount of immunogenicity in minority, approximately 10% of the populations which will prescribe these drugs. So let's talk about the biosynthesis of insulin. Insulin is not synthesized directly, rather it goes through what we call a precursor pathway. This is the precursor pathway in which original molecule which is synthesized through the process of translation, the peptide which is synthesized is called pre-proinsulin. As you can see in the structure here, this molecule contains an A chain, a B chain, a C peptide, and at the end an N-terminal signal peptide. The molecule synthesized in the beta cell moves to the endoplasmic reticulum where this N-terminal signal peptide is removed and the molecule becomes pro-insulin as it develops the disulfide bonds that are present in the insulin molecule. Proinsulin is then processed by the Golgi apparatus and converted into insulin containing A chain and B chain, and a C peptide is separated. It is important to note that C peptide is clinically very useful as it has a longer half-life than the insulin itself. So it serves as a marker of body's own insulin synthesis and secretion and is used as a marker of insulin level in the clinical practice. Let's understand how the secretion of insulin is regulated. Under the basal condition, the pancreas secretes about 1 unit of insulin per hour with much larger quantities released after meals. This secretion is controlled through three overlapping mechanisms, that is, through the chemical regulation, through the hormonal regulation, and through the neural regulation. Chemical regulation of insulin secretion is the core mechanism of regulation of insulin secretion. The structure that you see on your screen is of a beta cell. So the glucose molecule passing through the capillaries around the beta cell is taken up by the beta cells through GLUT1 and minor amount of glucose by the GLUT3 transporters. These are the specific channels present on the plasma membrane for the transport of glucose. This glucose enters the cell and is converted into glucose 6-phosphate by the enzyme glucokinase. And the beta cell's glucose sensor sends this glucose 6-phosphate. As glucose is metabolized and ATP rises, this rise in ATP actually leads to change in ATP-ADP ratio and indirectly closes the ATP sensitive potassium channel. Closing of this potassium channel causes partial depolarization of the ATP sensitive potassium channels on the beta cell membrane. This depolarization opens the voltage gated calcium channels. Calcium rushes in, and this triggers the membrane docking and exocytosis of the insulin containing granules. Interestingly, glucose produces a brief first phase pulse of insulin within about 2 minutes, followed by more usual sustained second phase. And while glucose is the principal trigger, amino acids, fatty acids, and ketone bodies also contribute to stimulating insulin release. The islet cells also talk to each other hormonally and control the insulin secretion. Alpha cells secrete glucagon, which stimulates the beta cells to release insulin, but insulin in turn inhibits the alpha cells, and that's a classic negative feedback loop because of which the glucagon increases the insulin secretion and insulin inhibits the secretion of glucagon itself. Glucagon from the alpha cells also stimulates the delta cells of the islets to release somatostatin. And somatostatin inhibits both alpha cells and beta cells, dialing down both glucagon and insulin release. So within the islet, you have this tight three-way regulatory circuit by which insulin, glucagon, and somatostatin are cross-regulated by each other. If we look at the neural regulation of the insulin secretion, then we can say that the islets are also richly innervated by both sympathetic and parasympathetic fibers. You can see the sympathetic fibers are controlled by the alpha 2 and beta 2 receptors, whereas the parasympathetic innervation is of muscarinic type of neurons. In terms of sympathetic side, alpha 2 receptors produce the predominant effect and it inhibits the insulin release by inhibiting the beta cell adenyl cyclase. On the other hand, both beta 2 stimulation and the muscarinic stimulation leads to increase in insulin release, but this effect of the beta 2 from the sympathetic side is less prominent than the alpha 2. The muscarinic activation that you see here from the parasympathetic side can be caused directly by the acetylcholine or by the vagal stimulation. Both of them increase insulin secretion working through IP3 DAG pathway to raise intracellular calcium level in the beta cells. Now that we know how insulin is released, let's look at what it actually does and understand that it acts differently across three major tissues. In the liver, the major action of the insulin is to switch off the gluconeogenesis. That is, it stops the liver from making the new glucose. So the glucose level in the liver and in the bloodstream can fall. In the skeletal muscle, insulin dramatically increases glucose transport into the cell. That is, glucose uptake by the muscle tissue for its metabolism. Whereas in adipose tissue, insulin promotes lipogenesis, that is, fat synthesis. Beyond these three, insulin also enhances glucokinase activity, inhibits lipolysis, while promoting triglyceride synthesis. Therefore, it increases the clearance of VLDL and chylomicrons from the blood and facilitates protein synthesis and inhibits protein breakdown. And it does all this across rapid, intermediate, and long term time frames. So, overall, insulin can be regarded as an anabolic hormone. So, now we need to discuss the molecular part to understand how insulin acts within the peripheral tissues like muscle tissue and in the adipose tissue. So, let's take it step by step. Insulin binds to its receptor, which you can see here are composed of they are composed of two alpha subunits and two beta subunits, and two molecules of insulin come and bind to this receptor, which is a transmembrane tyrosine kinase receptor that is on the extracellular phase. They contain insulin binding sites for the insulin. Because insulin is an extracellular hormone, insulin never enters a cell. So when they bind to the tyrosine kinase receptor on the extrinsic side, this triggers the intrinsic side of the tyrosine kinase, which actually phosphorylates a set of substrate proteins called IRS proteins or insulin receptor substrates proteins. From here, the signal splits into two major pathways. The first pathway is that it generates secondary messenger PIP3, which triggers a phosphorylation cascade shown here. And ultimately, this cascade activates various metabolic enzymes, and it also inhibits some other metabolic enzymes. But what is important is this cascade ultimately leads to membrane docking of a transporter known as GLUT4. This GLUT4 goes and docks with the membrane and leads to entry of the glucose. The glucose captured by this GLUT4 comes inside and it is internalized, releasing the glucose, and then it is recycled. So this is how this transporter goes out and brings more and more glucose into the cell. And this is how this process moves. On the other side, the pathway goes through RAS and MAP kinase, ultimately reaching the nucleus where it drives the process of transcription of regulatory proteins. This pathway is responsible for insulin's growth promoting effect, like cellular proliferation and differentiation. So you can see that one arm is responsible for the metabolism and other arm is responsible for the anabolic effect of the insulin. So what happens to the insulin after it has done its job? Insulin is distributed only extracellularly, and if taken orally, it will be completely degraded in the GI tract, which is exactly why insulin can never be given as an oral medication or as a tablet. After secretion, insulin travels through the portal vein straight to the liver. And here the key point is that 50% of the insulin that goes to the liver is degraded in its this very first pass. The liver therefore is exposed to concentration 4 to 8 times higher than the rest of the body. During this biotransformation, the disulfide bonds are reduced, separating the A and B chains, which are then further broken down into the constituent amino acids. The remaining insulin, which can escape this cycle in the liver, it goes on to the systemic circulation, which is then, after its action on the peripheral tissue, is cleared by the renal route. The plasma half-life of insulin overall is very short and is just 5 to 9 minutes. So this is all we are going to discuss about the insulin as a hormone. Now we are going to look at different types of insulin preparations which are available in the market. So shifting from physiology to pharmacology, understand how insulin preparations have evolved over the past century. In the 1920s, we had the animal extracts, and these insulins were purified from beef and pork pancreas through the extraction process. They actually worked, but they carried approximately 1% contamination with other proteins, which caused antigenic reactions. So they were highly antigenic. By the 1970s, we had highly purified monocomponent or MC insulins, which had less than 10 ppm of pro-insulin contamination. These were more stable and far less immunogenic. Later, by 1980s, we brought recombinant DNA technology and we developed recombinant human insulins. These were produced by using E. coli, yeast, or other enzymatically modified porcine insulin. The amino acid sequence were exact to the human sequence, and that is why we called them the human insulin. And from the 2000 onwards, we have engineered these insulin to produce insulin analogs. These insulin analogs are the molecules which have been deliberately modified to fine tune their pharmacokinetics while keeping the same pharmacodynamic effect. So here is the full class of insulin preparations that are clinically available in the market today. And these are the preparations that we are going to discuss in the rest of this lecture. These preparations are classified based on their duration of action. And there are mainly four classes: rapid acting analogs that contain insulin lispro, insulin aspart, and insulin glulisine. The short acting analogs is the regular insulin that is available in the market. That is the human version of the insulin. The intermediate acting analogs include the NPH insulin and the lente insulin, and the long actings include glargine, detemir, and degludec. There are more longer acting and some ultra rapid acting or ultra short acting insulin, ultra rapid acting insulin, which are available in the market, which are not discussed in this lecture. So let's first talk about the intermediate acting insulins, that is the insulin produced from the zinc suspension. What happens when you take an insulin molecule and you put it with the zincs? The regular insulin tends to form a hexamer around this zinc molecule, and that is why this formulation becomes stable. There are two forms of the zinc insulin suspension hexamers. One is an amorphous form and other is a crystalline form. The amorphous form is called semi-lente, whereas the crystalline form is called ultra-lente. So the properties of amorphous form are such that it is quickly absorbed into the bloodstream. So if you want quick onset, semi-lente will work. But this semi-lente will have a shorter duration of action. Means it will be absorbed quickly but will act for a very short duration. Whereas the crystalline form, that is ultra-lente, will be absorbed very slowly. But once it is absorbed, it will be available in the body for longer duration. So it will have a long acting effect. To get the property of semi-lente, the ideal property of semi-lente, that is quick absorption, and merge it with the long acting effect of the ultra-lente, the two are mixed in 70-30 ratio to produce what we call as the lente insulin, having a quick onset but a longer duration of action. And this is an ideal preparation. The second type of intermediate acting preparation is called as neutral protamine hagedon or NPH insulin. In this case, insulin is complexed with it is also called isophane insulin. In this case, we add protamine to the insulin that forms a complex with the insulin molecule. The protamine is added in just enough quantity so that the complex is formed, while neither insulin nor protamine is left free, and the pH is kept neutral because the molecule becomes soluble at the neutral pH. Once you give this NPH by the subcutaneous injection, this complex forms a depot and dissociates slowly, which is exactly what gives this NPH its intermediate duration of action. Clinically, this NPH has a longer duration of action, but again has a disadvantage because of its slow dissociation, that is, it has a slow onset. So, it is often combined with regular insulin, commonly in a 70-30 or 50-50 ratio, and injected subcutaneously twice daily before breakfast and before dinner. This mixture of regular insulin with NPH and given which is given twice daily is known as classic split mixed regimen. Now look at the rapid acting analogs, and in the rapid acting we are starting with the insulin Lispro. In the Lispro, the molecule is produced by simply reversing the position of proline and lysine amino acids on the B chain from B28 and B29 positions. What this change brings is that this small change causes the molecule to form very weak hexamers that dissociate rapidly after subcutaneous injection. The result is a quick, well defined peak and a shorter duration of action compared to regular insulin. So what happens is that when you take it is that you get a quick onset followed by a rapid decline of the plasma level of the insulin because of the quick dissociation of the hexamers which are there within the molecule. Clinically, this translates into better control of mealtime glucose spikes because after meal there is a rise in the glucose level. So, if you take this rapid acting analog, you will be able to control you will be able to achieve mealtime glycemic control. And after your meal time is over, there is less risk of postprandial hypoglycemia. That is, after meal between interdigestive period, you will not get hypoglycemia that you can get or that you are at risk of if you are using long acting preparations. While the insulin Lispro had the ability to form weak hexamers, insulin aspart has a tendency has a lesser tendency to self aggregate. So what they do in insulin aspart is that simply replace the proline at B28 position, which was replaced by lysine in Lispro. Here you completely change this proline to aspartic acid. This substitution actually causes the reduced tendency of insulin molecules to self aggregate, and as a result, aspart gives a time action profile very similar to Lispro. That is, the blood sugar rises quickly and then falls quickly. So, another important rapid acting analog is glulisine. In this molecule, lysine replaces asparagine at position B3 and glutamic acid replaces lysine at position B29 in the B chain. The properties and advantages of this molecule are very similar to Lispro, that is insulin Lispro. However, one important thing is that this molecule is favored for its rapid acting properties for continuous subcutaneous insulin infusion pump or CSII, which is used generally in people suffering from type 1 diabetes. Moving on to the long acting insulins, the first type of insulin that we have is insulin glargine, which is a clever piece of formulation from the chemistry perspective. In this molecule, two additional arginine residues are added at the carboxy terminus of B chain, and in the A chain at 21 position, glycine replaces asparagine. What happens is that because of these changes, this molecule stays fully soluble at pH 4, but the moment it is injected, subcutaneously and meets the neutral pH of the body tissue, it precipitates. This forms a depot under the skin. And from this depot, the monomeric insulin molecule dissociates slowly into the circulation. This gives glargine a delayed onset, means it does not have a rapid onset, but relatively steady blood levels are maintained up to 24 hours. That is a smooth, peakless profile. That's why it is suitable for once daily dosing without causing a peak in the insulin level, and it lowers the fasting as well as interdigestive glucose levels. Means it works both before meal, after meal, between the meal, irrespective of the time of the day it is given. Means irrespective of the fact whether it was given before meal or it was given after meal. The second long acting analog is insulin detemir. Detemir achieves a similar long acting profile but through a completely different trick. There is the myristoyl group, a fatty acid group attached at the B29 position. Because this myristoyl group is a radical group, it is easily attached to the amino acid lysine at B29. This fatty acid tail allows the molecule to bind to the albumin present in the plasma after subcutaneous injection. The free and the active form of insulin is then released slowly and steadily from this albumin bound reservoir. The end result is a pattern of insulin action that closely resembles the action of the insulin glargine. That is, you have a smooth and peakless profile as can be seen in the image. That is, it is smooth and sustained. There is no peak of the insulin level. Now let's put all of these together in one comparative table, that is onset, peak and duration. You can see that the rapid acting analog, that is insulin lispro, insulin aspart, insulin glulisine, have an onset time of just 5 to 15 minutes. They peak between 30 to 60 minutes and stay active in your body for a duration of 2 to 5 hours. Because of this, they can be injected at the start of the meal because they will be rapidly acting while you're taking your meal. If you look at the short acting insulins, which are the regular soluble insulin, it has a slower onset and it takes approximately 30 minutes to start showing its effect. However, the peak is also delayed, means the best effect of the insulin is seen after 1 to 3 hours. However, it remains in the body for as long as 8 hours. Because it peaks, its onset and peak both are delayed, it is usually injected 15 to 30 minutes before a meal, and it is available in the market as a clear solution. If you look at the intermediate or long acting isophane and zinc insulins are the more variables, right? And if you look at these molecules, NPH and lente have an onset of 1 to 2 hours, whereas the ultra lente has an onset of 2 to 3 hours because this is a crystalline molecule. So it peaks within 4 to 8 hours. The effect of NPH is seen for 8 to 12 hours, whereas the ultra lente, it takes it remains in the body for 24 hours because it has a delayed onset. It works for the longer duration, generally for 12 hours. It is generally used to control glucose levels between the meals because its action will be seen, the best action will be seen almost 4 to 6 hours after you have taken the insulin. So it will work better between the meals. And it may be combined with short acting insulin or the rapid acting insulin to control the mealtime hyperglycemia, and this intermediate will work, one will control the interdigestive hyperglycemia. Whereas if you look at the long acting insulin analogs, glargine and detamir, etc., they have an onset of as long as 1 hour. They never peak and they remain in your body for 24 hours, and they are usually given to maintain a baseline insulin level, and they are to be taken once daily. So the graph you show here is the visual story of the pharmacokinetics of the different insulin preparations that we have talked about. You can see the rapid acting insulin, that is Lispro, Aspart or Glulisine here. It rises fast, achieves the highest peaks very early and falls away quickly. So you take it at the meal time and control the mealtime hyperglycemia, right? So it's a sharp, short-lived spike, ideal for covering the meal. If you look at the second one, that is a regular insulin, it has a short acting effect, a slightly delayed onset than the rapid one, but a broader peak. So if you look at the medium acting insulin, intermediate acting insulin, like NPH, you will find that they give a sharp peak around 5 to 6 hours from time level 0. That is, if you take a meal at 0 hours and at the same time you take the insulin, the best effect will be seen at the in between the interdigestive period, that is approximately 5 to 6 hours after you have taken the meal, and approximately 10 hours later you will take the second meal, or 8 hours later you will take the second meal. So they are good products for controlling the blood sugar level on the interdigestive period if there is a peak of the sugar level there. Whereas you can see that the long acting insulins like glargine and detamir are active without a peak. They give a peakless pharmacokinetic profile, which helps producing a stable baseline insulin level active in your body 24 hours, reducing sugar 24 hours, irrespective of the time of the day when you take the medication. So this is how the four insulin preparations, four different categories of insulin preparations are used nowadays in the clinical practice. So the major clinical uses of insulin, of course, are for the treatment of diabetes mellitus. Type 1, they are used from day 1. In type 2, they are used when the oral hypoglycemic agents themselves are not sufficiently able to control the glucose level despite the titration of the doses. Secondly, they are used mainly for the management of gestational diabetes to prevent the side effect of oral hypoglycemic drugs, because also the gestational diabetes is temporary, so insulin is the best way forward. They are used in the treatment of diabetic ketoacidosis and for the emergency treatment of hyperkalemia. So this is all about insulin hormone and its various type of preparations. In the next lecture, we will discuss different types of oral hypoglycemic agents. Thank you.